Thank you. Thank you, Rohit. At the outset, I would like to welcome all of you to this lovely city of Kolkata, and thank you for making it here. And I would be talking to you about retained smile lenticule. Now, as far as the problems during lenticule extraction are concerned, sorry, they vary from 2 to 9%, and lenticule extraction may be difficult due to incomplete photo disruption, especially in the hands of novice refractive surgeons. If the lenticule is retrieved successfully, there is no impact on the visual outcomes, but if there is retention of the part of the lenticule, then this may result in the interface haze and may cause refractive surprises. So the retained lenticule and smile could be completely retained, or you could have just partial lenticular fragments which could be retained. Now, just to show some problems which can occur, especially such as in this case, this is a case where the smile lenticule is retained, and actually the anterior plane, you actually entered into the posterior plane. So if the air does inadvertently enter in the area between where the dissection has occurred and it has not occurred, you can actually delineate it and see it, and this can guide you to do a correct dissection in the correct plane. Now, there can be problems during the procedure, and that may also cause incomplete dissection of the smile lenticule. For instance, here you can see that there are some dark spots which are present here, and those dark spots, if you don't separate before you actually pull it out with the help of the forceps, you can see that there are stria here, and obviously it has not separated from here. Then this part may be retained if this is forcefully pulled out. So it is best to actually, with the help of lamellar dissector, separate it completely and then pull it out with the forceps to prevent this inadvertent lenticular fragment which may remain behind. Now, when you have opaque bubble layer, such as in this case, then actually the dissection may become difficult, and again there may be macro adhesions which may be present, and by the proprioception you can make out that it has not dissected well in that area, and every attempt should be made to dissect it completely so that there are no inadvertent remnants or tags which remain behind. This is again what I showed you earlier, a difficult dissection where if air does go inadvertently, at times it doesn't go inadvertently, then you try to see that it does, so that you can see the edge which is there and completely dissect it again, as has been shown here. So a completely retained lenticule, I think, is still easier to tackle with. It can be detected on the table if you have an intraop OCT microscope. If you don't, then you can shift the patient to the anterior segment OCT. And then Sinskey hook can also be used to rescue in the cap lenticular adhesion. You can peel off the lenticule from the cap. Alternatively, circle software can be used from cap to flap to peel off the lenticule. Another option which is there is that you could abandon the case, and this can occur especially if the cornea has become edematous because of your excessive needling into the or excessive attempt to remove it. And then one can do a retreatment at a later date using a cornea ablative procedure such as a PRK or LASIK, or else one can again in this eventuality also use a circle software cap to flap followed by examined laser ablation and then try to peel off the lenticule. I think the partially retained fragments are a little more challenging. Again, they can be detected on the table. On the table, you can detect it on the intraop OCT microscope if you have it. People have alternatively used trypan blue dye and tremesolon and try to remove it with the forceps, and sometimes even hydrate it out so that you can pull it after hydrating it, or do a customized ablation at a later date. Partially retained lenticule fragments do lead to irregular outcomes and can impact the visual acuity, and there may be increased higher order aberration subsequently, and the long-term visual outcomes may be suboptimal. This is our publication from the center where we did in the beginning, when we were still in the learning curve, use anterior segment OCT as a rescue tool during difficult lenticule extraction in smile, and this can be done. Only thing is that you will have to abort the procedure for that particular time and then take the patient to anterior segment OCT and then see and get the patient back and then remove the retained lenticule. And this is Dr. Ramamurthy's technique of using triamcinolone acetonide for remnant lenticule identification in SMILE. Dr. Sheetal has very nicely highlighted two cases how Circle software for management of retained lenticle tissue was used. Now, this was our case in which there was a retained lenticule, and intraoperatively there was some experience in the lenticular extraction which resulted in prolonged tissue handling, and it became hazy, the cornea became hazy and edematous. So instead of unbundling the procedure, it was decided to shift the patient under surgical microscope to intraop OCT microscope. And under the intraop OCT microscope, the posterior lamellar plane was highly reflective compared to the anterior lamellar plane, and so you can actually make out which part is the one which is dissected. So the part which is highly reflective will tell you that this part has already been separated, and under direct visualization of intraop OCT microscope, the peripheral edge of the adherent lenticule is separated, and then subsequently it does become easier, and also if it gets any difficult on the IOCT itself, you can see the hyperreflective area upon dissection, and also this can delineate the planes of dissection in a much more quantifiable manner. The free edge of the lenticule then, with the help of the microforceps, can be grasped and extracted using the continuous curvilinear sort of a lenticulorhexis procedure, and the procedure can be completed without any problem. So we've found this to be very useful. The only problem is that our both the machines are at different floors, so we have to actually shift the patient from one floor to the other because intraop OCT microscope is not placed in the same floor. But the current machines have intraop OCT microscope integrated into the lenticular platforms, and I think that is the way to go, especially when we all have shifted almost to the lenticular surgeries. So this was published as a new technique how IOCT can be used as a useful tool, not only for complicated cases but also routinely this can be used, and this was published way back in 2017 by our group. So to conclude, it is possible to manage, you can have retained lenticules more so in your learning curve or when you're beginning to learn SMILE, but it is possible to manage it, and you can manage it either intraoperatively at the same time or you can do it at a later date. Thank you very much for your kind attention.
Thank you, ma'am. But one of the biggest strength of the SMILE platform is the ability of it to give you rescue missions. You know, these, when you have a suction loss, when you have a large black spots, and that's one thing which is a very big plus factor when somebody's learning these procedures.
Yeah, I agree. I mean, that is definitely there.
Any other questions? Thank you, ma'am.
So just to tell everybody, this is an ISRS session as well, and which is the International Society for Refractive Surgeons. It's a global community of refractive surgeons, and wish to have everybody on ISRS platform as it's just been announced as an individual society all on its own. But having said that, we have to tell one of the board members also of ISRS, Jodh Mehta, who's going to be talking to us next on his topic of of management of presbyopic inlays associated complications.
Great, thanks.
All yours, Jodh.
So thank you, Ashwin, Jodh, and Dr. Renato Brazio, who is not here, for allowing us to include this session in All India Ophthalmological Society. I think this is being done for the first time, and thank you very much for that.
Absolutely. Thank you so much, ma'am.
Great. Can I have my slides? Great. Okay, so good morning, everyone. So first of all, I'd like to thank the organizing committee for this kind invitation to talk in this session. So I'll be talking about management of presbyopic inlay associated complications. These are my financial disclosures. So many of you will be familiar a few years back with the camera inlay that was used for presbyopic correction. Essentially, it's a pinhole device that basically improves the depth of focusing by allowing you to focus through this small aperture. The distance vision was minimally affected, and the idea was to basically place this under either a flap or a pocket, and the idea is to basically increase the depth of focus through this small aperture. However, over the years, all became familiar with some of the complications. Certainly in the earlier prototypes, there were minor complications, of course, related to decentration or loss of contrast sensitivity and glare and halos. You can see this thinning on the ocular surface underneath the epithelial flap on a patient who had it done probably about maybe 15, 20 years ago. But over the years, we just started seeing some major complications such as melt, hyperopic shifts, and a haze around the implant. And this is related to the cellular wound healing response. If you look at the cases that we did basically in Singapore, about 30% of our cases started developing haze, and unfortunately I inherited a lot of these cases into my clinic to try to help them to try to get some improvement. Initially you will see that the visual acuity results improved after they had the inlay with respect to their near vision, but you can see that basically when you look at pre-explantation, there was a reduction in the near visual acuity, and this was an indication that the implant wasn't really working that well itself. And about 30% of our cases developed this haze formation. 3 of these cases were placed under LASIK flap, and we noticed that they basically occurred between 3 to 7 years after the initial implantation. 6 months afterwards, after removal, there was some improvement in the visual acuity and some reversal of basically the hyperopic shift. The 2 groups of patients that I came across were really patients who had these under a flap device or under basically a pocket insertion, as you can see on the left-hand side. So of course a flap insertion inlay is actually quite easy. We were put under about 150 micron flaps, so you'll see these are slightly thicker than the flaps obviously that we do standardly for LASIK, but these are quite easy to lift. Even 3 to 7 years down the line, they were all basically done with the femtosecond laser. The pocket ones also actually surprisingly were also quite easy to actually dissect out, even though these were done almost 7 years after they were initially implanted, and I've opened them up even 10 years. The imprint of the device there, and I'll talk about a little bit in more detail, and that's really what we're going to have to talk about to get this removal. So this is an example of somebody basically pre-explantation. You can see obviously the haze formation there still basically post, and you'll see some improvement with respect to the change on the tomography on the surface following improvement. Now, if you take that inlay and you send it to the lab, this is basically what it looks like. So you can see under H&E staining, you see this luminescence basically affect itself. And then if you look at this in a little bit more detail across the surface of this implant, you'll see this fibrous acellular mesh across the surface. And actually what this is it's an acellular fibrotic reaction on the surface of the inlay itself. And what happens is that when you get this collagen reaction on the surface, it basically prevents the fluid going into the anterior lamellar cap, and that's why you get that flattening in the flap or the cap stroma and secondary changes on the epithelial surface. And interestingly, this mesh, this PVDF that was used on the camera implant actually is used for hernia vascular repairs as well, and actually you get the similar kind of response with the hernias itself. But of course, when you have a hernia repair, it's not such a big issue when you get this fibrovascular response compared to basically what you see inside the eye. So often what happened was you get situations like this where you basically get this haze left over. Patients have a reduction in their contrast sensitivity, and you can still have some residual basically hyperopic shift, and you can see this on densitometry, also basically on OCT, and likewise you see the same effect on tomography. So many of these patients were then sent to me to try to sort out, to try to see how we can basically help them in this situation. So what we did is that we basically came up with this idea about trying to basically do this as a 2-step procedure. So what I'll show you in a minute is that you'll see the haze both on the cap and basically also on the bed. So in the stage 1 of the procedure, obviously we remove the explant itself. Stage 2 of the procedure, you go back, and what we do is we laser the actual underside of the flap itself. And typically, once you can lift basically the LASIK flap, I put this on a evisceration spoon to basically balance this. You need to switch off the tracker off the laser itself, so you can see it on the spoon. You need to lie this down quite flat, and then I use a basically PTK module and then mitomycin C on the surface to help basically get the haze. And then basically after vigorous washing, you basically put the flap basically back down for a month before you basically tackle the bed. This is basically what it will look like after the first stage of the procedure. And normally, basically, once you leave it and it settles down, you can see at 5 months post-operatively, you get a reduction in the initial swelling, and you can get some improvement in the visual acuity. You then go back basically a few months later, and then what we do is you go back and lift the same flap up, and this time we laser the bed. And the options are here, dependent on not whether there's a cataract. You either use basically a PTK module, or you basically do an excimer ablation as you would do basically for LASIK itself. But again, the difference over here is that once you do the ablation on the bed itself, you then also have to do, we also use mitomycin C on the surface as well to help basically reduce the wound healing. So once you do the excimer ablation, then we put mitomycin C, again, exactly the same way as you do for standard surface ablation in your cases, and then this is basically washed, and then the flap basically replaced on the surface. And this is kind of improvements that you can get. It will not go completely, but you get quite a reasonable improvement, and likewise some improvement with respect to the visual acuity results as well. And you can see on the OCT you get some kind of improvement as well. This is kind of some of the cases that we had initially looking pre-op. This is basically 6 months post improvement in vision after the first ablation on the cap, and this is basically after the bed ablation as well. If you want to use a nomogram, this is something we published basically in JRS last year. It shows you whether we choose whether to do PTK or basically PRK, and you'll see an improvement with respect to the spherical equivalent, of course, after the laser ablations, and also improvement on densitometry using the pentacam after you've done the ablation treatments itself. The main basically factor with respect to how much haze you remove will be dependent on the severity of the haze following the explant removal. So I do counsel the patients very closely with this, because this is going to basically determine the outcome from how much haze we can remove itself, because of course there's a limitation with respect to how much stromal tissue you can remove. So the small aperture corneal inlay causes acellular extracellular matrix reaction in the corneal stroma following implant removal. This has an effect on contrast sensitivity and aberration reduction. Sequential laser ablation, either PTK or PRK, to the bed and the flap can basically reduce this. I do this as sequential procedures to basically try to refine the refractive outcome. And the variation is dependent on the degree of the host explant haze. Some of the cases do have very severe haze, and of course you have to counsel the patients. You're not going to be able to get rid of it completely, but you will get significant improvements. Thank you for your attention.
Thank you, Dr. George. Just a question. The percentage of people developing this haze is what, in your 8%?
So they were implanted like when I first went to Singapore, so like 2007. I'm quite happy that I hardly did any of them. I think that 60 were implanted in Singapore, mostly under trials, and I would say probably about 30 to 40% get haze, and I've taken out about 30%. So I've taken out at least about 25, and that series is about 12. I mean, bearing in mind in Japan they put 10,000 in. So, yeah.
So one of the things which I was thinking when you're presenting is if they have a higher threshold of having more ocular surface related inflammation driven by the TGF or TNF alpha pathways, you know, they are the ones who would behave completely different when you put anything in the cornea. It's just like doing a PRK. Yeah, so I think you're correct. I mean, I think that there would be a difference in whether they would get haze. Not with this inlay, but with raindrop inlay, we did study cytokine profiles and stuff as well, because they also had stromal issues and stuff. So there was a whole series of cases, I think, done in Mexico, and they took tear samples and they sent them to us, and we did analyze the tear samples as well, and we did see differential responses with the ones that had the inlay in versus basically not the inlays. But you would expect a difference, but actually we're seeing this now. I think, honestly, I would advise you, if you have patients with these inlays in, I'd take them out, because they all have some sort of haze response, and I would remove them, definitely.
Yeah. Here.
So in fact, I have a series of 3 patients that we did 7 years back. You're right. One patient had a severe haze, so we had to lift and remove the inlay.
Yeah.
The second patient had a cataract.
Yeah.
So we just did away with the cataract, but there was just cellular infiltration all around the inlay.
Yeah.
But she's doing well. She's one of my OR sisters.
Yeah.
So I was just asking, once you lift the flap, how much is the target ablation that you're doing on the undersurface of the flap?
So I measure it on the OCT. So what I do is I measure it on the OCT. Remember, the flaps were basically created for about 150. So I do basically between about 40 to 50 microns, and then I actually use the OCT to basically on about 5.5 millimeters when I do the ablation on the flap itself, and you get some quite decent improvement on that. So what I do is when I see the inlays in, if there's no hyperopic shift, and they have a cataract, then I do the same. So I do cataract surgery on them, and I aim for a myopic outcome, like 0.5, 0.75, so they can start to try to use the inlay. If the patients have a hyperopic shift pre-op, then I tell them, I either pre-treat them with steroids, or I tell them to remove the inlay first, and then I tackle the problem by then treating the haze, and then I do the cataract surgery after that.
Now the question is for the third patient where
Yeah.
I did it under Zimmer. I made it a pocket,
Yeah.
and then now there is a haze.
Yeah.
So what do? I can't lift.
No, so what I would do is that I would use the Circle software from Zeiss, and then basically make that pocket into a flap, and then lift the flap up. That's what I would do.
Okay, so the parameters have to be taken from that.
Yeah, so you can take that, but you see that your pocket was probably, your pocket was also probably about 150 as well, right? Yeah, correct. So you can do OCT to give you some sort of idea, and the Circle software allows you to have a 10 micron side above and below. So I'd aim for basically 150, and you're going to get very, very close to that level of the interface. So I'd make it into a flap, and then you can start with the
Pocket to
whole
a flap.
haze, and make it into flap, and then start with the whole haze induction from there.
Thank you. Thank you, Dr. Jod. Move on.
Thank you, Dr. Jod. That was rather innovative presentation. Extremely nice. I'll call upon Dr. Rahil Chaudhary. He'll be talking on silk versus contura, what to choose. Rahil, please.
Thank you, Rohit sir, Namrata ma'am, AIOS, ISRS for inviting me to this wonderful conference. So I'm talking about a new technology, a new name that is creating a lot of buzz in refractive arena, which is by the name of silk. And a lot of doctors are asking this question, if silk is actually an upgrade, or is it just an hype, an old wine in new bottle? So let us understand more about silk. So until 2023, we had some popular options in refractive surgery. Some of them were flap-based options like customized LASIK or Contura. Then you had flap-less options like Smile being the most popular. And then you had surface ablative options like PRK or Streamlight, or otherwise very popularly known as Epicontura also. And now in 2024, we have another name or another machine or another technology coming in by the name of silk, which is basically a second generation femtosecond lenticule extraction procedure, refractive surgery by Johnson & Johnson. And the question that is coming now is that, is there a need to upgrade when we already have extraordinary technologies like Contura and Smile with us? Do we really need to upgrade to another platform in 2024? So let us first understand, how does Contura and silk compare? So over the times, we've realized that 5 to 10% of the patients really get the Contura advantage. The remaining 90% of the patients have minimal higher order abrasions or irregularities. And even if you do a Contura treatment for them, the results are almost similar to an wavefront optimized treatment. So we understand that a careful pre-op evaluation is necessary, and only 5 to 10% patients would actually need an Contura advantage. So the rest 90%, let them have a flapless advantage. So again, what I was telling, what is Contura? It is a topo-guided LASIK correction approved for virgin eyes. Minimal number of patients really get advantage, the visual excellence from Contura, and let the other 90% get the flapless advantage. And then we have Smile, which has been popular for so many years now. And now we have silk coming in with the second generation femtosecond platform. How do these two compare? And why is there a need now for Contura and Smile users to upgrade to silk? Is there an actual silk advantage to it? Let us understand that. Well, the first advantage is, as the name suggests, that it is as smooth as silk. So never seen before such beautiful dissection-less extraction procedures. So just showing you one quick video. And why is it actually called silk? So open up the anterior plane, open up the posterior plane, and then when you have to put any effort. There is virtually no resistance. It is something like slipping your instrument in the interface and it's done. And now I'm going below the plane. It just comes out like wow. This is the beauty of silk. It is virtually dissectionless. What is the second advantage? For the first time, we have something called as bridgeless laser spots. And this is the reason why the dissection becomes so smooth, because now your spots are actually touching each other with 1 micron spacing, and you have amazing quality of dissections. And I want to show you here and emphasize here, 0% of cases required significant dissection, or they were actually 0% cases which were difficulty to remove the lenticule. What is the next advantage? The third advantage, the advantage of the lowest energy possible. So I've put a picture here where I've compared the latest femtosecond platforms available, and you can see here that Elita or the silk machine is working at a minimal energy of 40 to 90 nanojoules. Now, what is the advantage of working at such low energy? The collateral tissue damage is minimal. And the first day post of wow is amazing. So we actually have patients next day, most of the patients 6x6 with a wow factor. Then what is the fourth advantage? The advantage of first in industry biconvex lenticule with silk. So how does it benefit? I've copied this picture from Rohit sir's presentation. Sorry sir, I could not click this. I don't know which OCT is this. So this has just been copied from Rohit sir's presentation. And what we understand here is that when you make a biconvex lenticule, it mimics the natural anatomy of the eye or the cornea. And you have better depth of focus. So we say that the depth of focus is almost comparable to an e-metro patient with natural quality of vision, minimal change in Q value and spherical aberrations. So this is the fourth advantage of silk. Let us see the fifth advantage of silk. The fifth advantage of silk is the fastest nerve regeneration. Again, copied from Rohit sir's presentation. So this is the work done by Rohit sir and team Narayan Nitrale, and extraordinary results. And you can just see here 1 month, 3 months, 6 months, how the nerves are regenerating. And this is the reason why patients have highly reduced dry eyes. Let's look at the sixth advantage. Fastest vision recovery, and I'm giving you honest figures here. People may claim that they get 100% patient 6/6 the next day, but no lenticule extraction procedure can give you 100% 6/6 the next day. But the highest number that we're attaining is with silk. So we almost see 89 to 90% of the patients 6/6 next day with the wow factor, and 0% of patients lost any of the visual acuity lines. Let us see what is the seventh advantage. 100% satisfaction done in a study. So I think it is high time that when we have technology, we should upgrade and give our patients the advantage of the latest tech available. Thank you.
Any questions for, yes please.
So Dr. Rahil, you said that Contura is needed only for 5 to 10% of patients. So Silk has been recently launched, but Smile and everything was there. So were you doing Contura only for 5 to 10% of your patients?
Yes. So initially, what we were doing was that Contura has been approved for virgin eyes, normal corneas with minimal irregularities. And the idea was that when you correct these irregularities, you are able to give a visual excellence advantage to the patients. But over the time, doing so many Conturas over the years, what we've realized is that only 5 or maximum 10% would really get that supervision advantage. Other patients, the results are comparable to wavelet optimized.
So exactly that is what is my point. Silk has been launched recently, and we are all gaga for Silk, that Silk is doing very well. Because when Contura was launched, this was the same thing for Contura, that Contura is the best possible treatment. And now on this platform, we are discussing that Contura is beneficial only for 5 to 10%
Yes,
of
because
people.
you see, if the other 90% of the patients are getting the same vision quality with Contura or Silk, then why unnecessarily create a flap on the eyes?
Monica, if I can answer a little bit on that, it's like, see, ECC also gives the same 6 by 6, and people are very good at the extracapsular surgeries. But why did we move on to SICS and why did we move on to submicron is if you are able to give the same results of an extracapsular surgery with minimal invasion of a corneal tissue, that's what we call it as an advantage. In refractive surgery, if you look at the genesis of refractive or cataract surgery, it's all about, if you are giving the same safety as you are doing it with the Contura, with minimal thing and with minimal damage to the corneal nerve, with minimal changes in it. So that is what we should take it as a leap in it. So like I said, the comparison is a thief of joy. I mean, we do Silk, we do Smile, we do Contura, but the issue is that how beautifully you can take out a power with least amount of collateral damage. And that is what I would say all this technology, whether it's Smile with faster thing or ETOS or everybody has that advantage of it. That's how we have to take it in.
Rohit, just to add to that point though, I have to say that just to your question, she's right, because at the end of the day, the golden standard for this would be an RCT comparing Contura to a lenticle procedure. So even though, even though of course, we will I do a lot of lenticle extraction, it's not that I don't do any LASIK at all, and in fact all the LASIK I do is basically Contura based or topography guided based, but the definitive answer to that question is to basically do a proper RCT with one eye topography based versus a lenticle procedure, because that will give you the question, because you're saying about doing these kind of lenticle procedures because of other advantages, the dry eye, ocular surface and things like that, which we all basically believe in as well. But to answer the specific effect of procedure versus specific procedure, that's the evidence. And the evidence, to be frank, from first generation lenticle procedures against topography based systems actually is in favor of topography based systems. Now what you're seeing is from all the technology, there are second generation procedures which should improve their outcomes. So that will hopefully, basically somebody will do a study. I mean, everyone has LASIK machines, so maybe somebody here will do the study to answer that question.
Thank you. Thank you.
Great. So it's my great pleasure now to invite my good friend, Dr. Rohit Shetty, who's going to be talking about a very important topic, dry eye disease and ocular pain. Thanks, Rohit.
So in between multiple beautiful technologies and videos, I just want to bring in the concept of dry eye, which many times is completely ignored. But one unhappy patient with ocular pain can mess around with the entire practice. These are my research with whom I work. I know nothing directly linked to this presentations. So if you look at basic pathophysiology of pain, it starts with injury, how the nerves respond to it, release of neuropeptides, and what it does once it releases, how it works on your inflammatory mediators, and this is how it works. And anything which you work on balancing it is something which can reduce your pain aspects. One major challenges which we see both in our clinics as well as in post-refractive surgery is pain without stain, where you have all your parameters in normal, but they're just not happy. They just keep coming to you being unhappy. And there is an aspect of neuropathic pain, and there are a lot of related stuff on this, systemic disorders, ocular surface injuries, medications, it can including neurological and psychological problems. So one is about having a lot of extra nociceptive effect. That means you are more sensitive, and these have two neurons. We can subnormal and abnormal inputs, which can be allodyna. You do have a lot of questionnaires on this, and symptomology, most of them do suffer from more than 3 to 6 months, and there are different methods to evaluate, from aesthesiometry to topical anesthetic tests to see difference between the central versus the local causes of ocular pain, and of course the role of confocal microscopy. One of the most important thing in confocal microscopy is ability to pick up neuropathic pain versus an ocular inflammatory driven pain. these cells, for many years, we were looking at it as dendritic cells, but now we have to look at the re-terminologies. These are T cells. They don't have those dendrites. They are those white dots here. And mature dendritic cells, and you can have a mix of dendritic cells, and some of them lying very close to ocular subbasal nerves. What we have published is if they're closer to the nerves, the pain is more. And this is something which happens by chance or by nature. You got nothing to do with it. There are so many of them who may be away from the corneal nerves, and they will just not have those pain factors there. And there's a huge component of microneuromas which we don't pick up. And these microneuromas can be a major factors from ocular pain. So can we have a classification system? This is me and my colleagues did publish this paper, which is a discordance scale, where it's difference between the symptoms versus the signs and how the discordance between them. And if you look at the confocal microscopy, again I shown you the picture. The microneumas again shows chronic pains. Dendritic cells are changing, dynamic. So if you treat them with steroids or keep them on immunomodulator, probably they might actually reduce. If you look at the molecular aspect of it, we studied with in the initial part of the paper where we used the CBA analysis to look at all the molecular factors. And you can clearly see that there's specific molecular pathways involved in pain, and this is driven by the interleukin 17A. Why is it important? Is because when you know that there are specific markers which are linked to pain, you can look at markers which can actually reduce it. And this is something which is very chronic post-cataract surgeries, post-refractive, post-vitreoretinal, many things. And one of the reasons we had to look at the role of vitamin D in this neuropathic pain is what we published here. The patient's vitamin D has a huge impact in maintaining the nociception. It controls the nociception. When you have a low vitamin D, the nociceptive factors increase. So that is one of the reasons is all the factors here which are necessary for nociception increase. That means the person who becomes 100 times more sensitive than somebody who has a near normal vitamin D. And this is also driven by vitamin D receptors in your cornea. So there's no uniform algorithm to manage this pain. So what we looked at, say, if you're looking at this particular case, in the interest of time, I'll run fast with patient non-resolving pain, and you can see that his T-but is low, but no staining, but you can OSDI is on a very high level. All the other parameters looks completely healthy. But what we started looking at with our the point of care kit is where we have a stall in AIOS this time where you can analyze your tears and you understand what it does, is these patients had a very high level of certain markers, and one of the markers which I did mention in the past was IL-17, which is not always controlled with your steroids or your cyclosporins or your tacrolimus. So what we did was in this patient, and this again we published, microneuromas have a very high level of somehow they are linked with the IL-17 response. So what we did was, in the past we had published this work where we used the intrinsic pulse light or IPL therapies. This was an highlight at that point of time. And what we found was one of the factors which was very well controlled with this was IL-17. So this is how you look at how you can use it and titrate it, and even MMP9 can be controlled by your LipiFlow. So when you combine both, it works as a very good combination, and you can see that both your markers suddenly drops down, and this is just with one sitting, and pain also starts reducing. So there's no specific marker which can block the MMP with the IL-17. The cyclosporin does work on IL-2, IL-6 and MMP9, but that's why you have to combine sometimes therapies. And when you need combine, because the LipiFlow works extremely well when you have a high level of MMPs or IL-6, and IL-17 works well with IPL. And when you combine both, this is what we get. And this is again a patient who was advised LASIK, but when you see closely, there are microneuromas. And if you do a LASIK and you damage those nerves, it's chronic neuropathic pain again for life. So what we did was, and this is a confocal microscopy of it, what we did was we went deeper. We went 150 microns in this patient. We can use the smile to change your cap depth, and you can see that the microneuroma still exists without disturbing it, without much changes on her ocular surface or her pain status. So this is just a brief flow chart of what we look for if you have access to it. Ocular surface inflammation is a major one. It correlates with OSDI. Microneuroma has a huge impact in your neuropathic pain, and binocular single vision. When you have a very, very bad stereopsis, you complain of pain which mimics a neuropathic pain, but it could be related to his stereopsis. And it's very important to always look for his stereopsis before you label anybody on this. And this is just a flow chart which talks about anti-inflammatory therapies of cyclosporin and dysregulated. We have to really, there are so many areas where it's need for future therapies, where you need to look for targeted therapies. And when you know that it's a neuropathic pain without any ocular surface issue, there are role of autologous serum, tricyclic antidepressants. So the pain without stain is quite common in refractive surgery. The commonest one is binocular issues, not the corneal issues. And the role of molecular assay and future therapeutics will probably help in managing this much better. Thank you.
Well, I'll just ask a quick question. It's excellent talk and on a really important topic. Can I just ask two questions? One is, from your experience, what is your estimate percentage of neuropathic pain in refractive surgical patients? And the second thing I was going to ask was, one of the advantages of your point-of-care kit is really the fact that very few people have confocal. And I think that that's a game changer for a lot of people if you can, more people can get that point-of-care testing kit to use, because there's issues with the HRT machine itself, and I think that would be a big game changer for a lot of people. Yeah.
The classic neuropathic pain, the percentage is very less, maybe 0.1% or less. But patient comes with pain. Most of our pain patients all have binocular issues, because when they feel stress, when they start working, eyes start hurting, it's labeled as neuropathic pain because they don't find anything else in it. So that's the first thing. The classic neuropathic pain is very less, but whenever we see ocular pain, or if you just do the confocal of them, most of them end up having some microneuromas, or a lot of those T cells. But T cells, when you have, you know what to do, you can treat them. But because the pathways of pain is driven, 3 papers we published is classically driven by the IL-17A pathway, which changes the ocular epithelial cells. We feel that combining it with any of your IPL, for some reason it works well, or all IPL works well, plus the LipiFlow reduces pain in a lot of them because it balances both the factors.
Yeah.
The point-of-care kit is now becoming a reality. There's a stall there where you can pick up and you know which part of the immunology you're dealing with.
But how long will the LipiFlow work for? Because of course it's just a one session treatment, right? So what's your duration of action? So there'll be a window period in which you have to do your refractive procedure.
LipiFlow, if you do a LipiFlow and take the patient next day, the eye is filled with inflammatory thing. So we wait for a week.
A week. Okay, great. All right, thank you.
I'll invite Dr. Ashwin Agarwal to talk on ICL surgery complications. Ashwin, please.
Hi, thank you very much. We'll be talking about phakic ICLs and its complications. Obviously, thank you, AIOS. And just in interest of time, we're going to do away with the questions till the end of this session because we have the next session as well. And we're running a little late on that. But coming to the topic of phakic ICL complications, I think my lens-based refractive, complete focus has been ICLs and predominantly star ICLs. So we'll not obviously have financial aid with LSI, but it has nothing to do with this talk. We're going to be talking specifically about star ICL in this scenario because I have experience only with that. And I'll just give you a little bit about ICLs. And the disclaimer is that 99.1% whatever percentage you can think about do go well. So whatever we're discussing here is a very, very small fraction, but it's something that we all should know about in our daily practice if we are going to get into phakic ICLs at any point of time. So here you can see understand the ICL is extremely important. That's the orientation marks. So if you even rotate it 360 degrees, it's always going to be in the same orientation, bottom left, upper right. One of the hints that I can tell people, especially beginners who are going to start this, hold your steering wheel in that position, and that kind of becomes your norm when you're starting this procedure of phakic ICLs. So I think pearls and pitfalls which I want to get into in complications of phakic ICLs is going to be during investigation, what are the complications, during surgery, what you can face, and post-operatively what you can face, and how do you deal with it. So before we move into any of this, I think we first have to talk about the investigations that we do. These are the set of investigations that we do. The two most important ones being the pentacam and the ASOCT. The pentacam and ASOCT give me two big values. One is the AC depth, which I obviously have to measure both, and you have different techniques to measure them. But also the horizontal white to white, which is obviously used not just by us, but also the company guys who actually measure and size this ICL. And we'll come to the sizing in the post-operative segment, but that's an important part of the discussion, is the investigation and how this connects to the post-operative, because everything in ICL is diagnostic based. If your diagnosis is right, your ICL pretty much goes rather smoothly, except if you have an intraoperative issue, which I'll come to. In intraoperative issue, the first step is loading. Don't allow the loading to happen by someone else. Do the loading yourself. Ensure that there are no air bubbles in this viscoelastic injection in the cartridge. When you place the lens, make sure that you're concave down and convex up. Holding the ICL and pulling it all the way through is extremely important, but even more important is visualizing the orientation holes through that. Outside the eye as a reference point. So use that. I'm going to shut this off, but the basic idea is use the reference point of this cartridge lock which you're seeing over here. The cartridge lock is your only reference point when you're inside the eye. Use that to pivot left or right and make the holes face you at all points of time. The holes should face you at all points of time. That's the key idea here. So in case it's on the left, you actually turn the cartridge to the right and then inject. It avoids the complication of a flipped ICL. You will not have a flip in the ICL if your orientation holes are facing the microscope at all times. So just make sure, because it can twist while you're pulling through that hole. I'll just give you an example of this. So what I do usually is, under a topical anesthesia, of course, I do make my Wong incision in these scenarios because I want a closed, tight-lipped wound. Once I have placed it, I'm already seeing my orientation holes, if you can see here on the left, bottom left. Once that is placed, I am putting the foot plates under the iris, and the foot plates can go under the iris. I'm using a simple wire rod system and to kind of pivot this into pivot the foot plates under the iris. And once it's in place, this is a non-toric, but you can always place a toric by rotating it. It's rather simple and easy to rotate. Once that is done, you irrigate the fluid. I use a Simcoe cannula. I know the rest of the world doesn't use it, but it's kind of quite controlled in these scenarios, especially when you want to go under the lens and so on. That really helps. If you have a flipped ICL, one technique that we talk about a lot, and I know it's a slightly cringy topic to talk about, but which is visco inversion. What happens in flipped ICL is you get a rotated one. It's not 360 degrees, it's a flipped one. So the orientation holes will not be in the bottom left, upper right, it will be in the exact opposite portfolios. This is a resident of ours who is actually intentionally flipping it without realizing the fact that he was doing this. And so when you come into a scenario like this, a bimanual visco insertion, so visco inversion technique is used. So you basically fill the chamber with viscoelastic and flip the ICL on one pole into the angle, and that kind of rotates the whole ICL across. And we've done at least more than 10 to 12 of these and had absolutely great results. We have this fear that the endothelium will get scraped. We have the fear that this, but honestly speaking, if you have a visco cannula in your hand and you're constantly filling that bag, there is a very less risk of this happening, and you can do away with damaged ICL, because while you're trying to pull out an ICL, there can be a little bit of damage, then you have to wait for 3 weeks more and then do the procedure. So those risks are aborted. Try this, and anyways you have that risk of damage and so on and so forth. So that's one way, and the other obvious method is explantation, but you have explantation requirements in any of these complications if you have. So explantation is rather simple. What I started to do a lot more is just make sure that the ICL is free, hold it at the optic haptic junction, and that's directly in this angle, and just one cool pull out, it comes out through a same incision that you went in with. You don't need to extend the incision like in the other phakic lenses within India, but I think those are some of the huge advantages because of the polymer material that this is made up of, and that really lasts for even 20 years later. You can pull it off through the same incision size. So quite a few advantages here. I'm just showing you in these cases the cataract procedure as well, because the requirement over here was a cataract procedure for us to remove or explant, and the post-op day looks good. You don't have to really worry too much about that. The effect of the central flow is that you really reduce the risk of angle closure and reduce the risk of cataract formation. Sizing, these are the sizes that STAR sends, and you might want to note this because it's extremely important in sizing. If you have a large white to white, you please go horizontal. If you have a smaller white to white, you go snug fit. The thumb rule is keep it a snug fit always, rather than keeping it a loose fit, especially in the toric scenarios. Vaulting is extremely important, and for which sizing is key. The ideal vault you want to reach is 250 microns to 750 microns. The low vault is below 125 microns, and a high vault is 1000 microns or 1 millimeter or more. So this is the thumb rule which you want to use. The sizing, what should I do? What should the treatment be in any case? If you have a low vault, wait and watch if there are no symptoms. Guys, that's the general rule. Just wait and watch. If there are no symptoms of the patient, just wait and watch. It should be fine over a period of time. If you have symptoms, exchange the ICL, increase the size of the ICL to make it a snug fit. If you have a low vault, that means it's not sitting too high. If you have a low vault, you want to increase the size so that it fits snug and sits up. If you have a high vault, you want to reduce the size and make it fit little low. That's the ideology behind which you want to work with. So that's why the sizing is quite key and important to understand. Just go one size lower. Unfortunately, the sizes as I showed you is in 0.5 steps and not smaller. I wish they were smaller. We would have used that as well. Axis and rotation, use direct visualization. You can use a marker with a slit lamp, or in the new age digital marking system also has a lot of impact. Other complications, you can have endophthalmitis, CME, damage to the ICL, as well as retinal damage and uveal retinal detachment and uvea and glaucoma issues. These are some of the complications of ICL. Obviously, to a larger length, we can talk offline. But right now, thank you very much for this talk.
Thank you, Ashwin. No doubt, ICL is a very successful and rewarding surgery. Sometimes it really gives us amazing results. I think it's time for the next session, and I invite the chairperson of the next session.
No. Two more talks to go, actually, yeah. My name is Dr. Vishal.
Vishal?
Yeah.
Okay, yeah. Sorry.
So the next speaker is Varman Kankar. He's going to be talking about management epithelial ingrowth. Thank you. So first of all, from the All India Ophthalmic Society Scientific Committee, we would like to again thank ISRS for this collaborative session. Friends, I'm going to take you through, I think the color is changed. It's coming like this. No.
Vishal, do you want to start off on the?
Yeah, I think we can take, yeah.
Yeah, Dr. Vishal, I think maybe you can.
Yeah. Oh. So Vishal mentions he's from Punjab.
That's what my badge says. It's a good thing. All right.
So Vishal's going to be talking about post-refractive surgery keratitis. Thanks, Vishal.
Is it done? अपना है All right, okay, all right. Well, good afternoon, everyone. I know there's a time crunch, so I'll be talking about keratitis after refractive surgery. I'm glad all the good talks have already happened. I don't have any relevant financial disclosures. So, general overview, keratitis can happen basically after any refractive surgery. Surface ablation, LASIK, cross-linking, intracorneal rings. It depends what you do more often, and then you will see keratitis in that kind of surgery. If you're a PRK surgeon, you're obviously going to see a patient with infection. I hope not, but yes, you will end up seeing one in your lifetime. Just, I have to mention that there is a declining incidence worldwide of post-refractive surgery keratitis, and this can be attributed to a few things: increased index of suspicion, better diagnostics. I think microbiological techniques have become much better over the past 10 years or so. There is a lot of emphasis on equipment sterilization. It might not be relevant to where I work, but it's probably relevant to many other countries. And definitely the use of fourth generation fluoroquinolones has been a game changer, really. So some numbers, it's more common after surface ablation compared to LASIK. Contributing factors can be a large epitheलिal defect, use of bandage contact lens. You can't avoid that after PRK or LASIK. The use of topical steroids is a common risk factor for both surface ablation and flap-based surgeries. Risk factors, this list also gives us an idea of how we can prevent keratitis after refractive surgery. Blepharitis, the number one reason. So you really got to examine the lids before the surgery. Dry eyes, any trauma, intraop epithelial defect, excessive manipulation of the flap, intraop contamination that can happen. If there's a delayed post-op reepithelialization because of a risk factor that the patient already has before the surgery, and of course contact lens use, as I mentioned earlier. Keratitis after surface ablation presents with pain, decreased vision, redness, severe photophobia, discomfort. You will see conjunctival injection, residual or a new epithelial defect depending on the timing of presentation, and a discrete corneal infiltrate, like you will see in any patient with keratitis. Common organisms include Staphylococcus, Nocardia, and Fusarium in surface ablation. Management, obviously, we always encourage folks to get access to good microbiology labs. You don't need to wait to initiate fortified antibiotics. 50 to 90% of cases seem to resolve with some sort of scarring, and in the previously published studies, the corrected discerned visual acuity would be more than 20/40 in most of the patients. It's less common after LASIK. Fortunately, you can see the incidence can vary anywhere from 0.03% to 1.5%. Again, depends on the sample size and also on your practice, where you practice. The onset of keratitis can be early, which is defined as occurring within first 2 weeks, and late, which is after 2 weeks to 3 months post-operative. Although you can see post-LASIK keratitis happening years after the initial surgery. Common bacterial pathogens, they are sort of causative organisms in early cases, staph, strep, and gram-negative organisms, which are really rare. In late onset, you can see more fungus, nocardia, atypical mycobacteria, and sometimes acanthamoeba as well. Clinical features again include pain, redness, photophobia, and reduced vision. Atypical pathogens which are seen in late onset keratitis, they can have sort of a more indolent course with foreign body sensation. You might not see a proper infiltrate, you might not see a real epithelial defect in some of these patients. It is important to differentiate between DLK and microbial keratitis, which is really not very difficult. DLK usually happens when the first week, involves the interface, sort of diffuse, cloudy picture, and responds to steroids very well, something that keratitis will not, definitely. It'll get worse, actually. You should lift and scrape the flap. I'm not going to show this video. Basically, to take scrapings not only from the bed, but from the undersurface of the flap as well. One of the additional advantages of lifting the flap is also debulking the actual infection. I mean, you're getting sample from microbiology and you are decreasing the load a little bit. And while you're in there, do not miss a chance to irrigate the bed with either antibiotics or antifungals. You can do both if you like. Specific antibiotics, of course, for atypical mycobacteria, you can use amikacin, or you can also give systemic erythromycin. For nocardia, again, amikacin and cotrimoxazole, which is easily available in India. For fungus, we have started using more voriconazole, but again, it depends on the organism. You can use netamycin and systemic voriconazole or ketoconazole. For acanthamoeba, we use the usual PHMB and chlorhexidine combination if possible. This is a patient post-LASIK keratitis presenting with live perception vision and gram-negative organism Pseudomonas, treated successfully with tobramycin and cefazolin and systemic ciprofloxacin as well. You're basically throwing everything that you can to save this patient's eye, and you see this patient actually healed very nicely with BCV of 2060 with contact lens fitting. This can be devastating as well. This is a severe infection after epilepsy where the patient needed a large limbus to limbus, actually beyond that, corneal transplantation, but really did not too bad after all this ordeals. We published this case, microbial keratitis, after an intracorneal ring segment was infected. So basically the treatment is you basically have to take the patient to the OR, take the ring out, and irrigate that channel with antibiotics and antifungals if you need to. This is a patient we saw recently, acremonium keratitis after LASIK. The patient presented a few weeks after initial LASIK, which was done elsewhere with a discrete infiltrate, but got worse. And we really had to take the patient to the OR and amputate the flap and irrigate the bed with antibiotics while the patient was started on fortified antibiotics, which were later changed to antifungals. This is how the patient looks a month after a flap amputation and continuous antifungal treatment. This is how the patient looks 3 to 4 months later. You can see there is a residual scar, but we were able to save the eye. So to conclude, you really need to have a high degree of suspicion in these patients. Prompt initiation of treatment is very important while you're waiting for the microbiology results to come back. It is important to do an early flap lift to obtain culture and flushing the interface with antibiotics or antifungals, and you got to choose your empirical therapy based on your geographical location and your practice pattern. Thank you very much for your attention.
Okay, Dr. Vishal, we are already running a little bit late. Dr. Vardhaman, please.
Yes, thank you so much. And I think in the interest of time, I'm going to keep it short. If I can have my slides on, please. Yeah, perfect. So friends, we all know that post-LASIK or smile epithelial ingrowth is a rather uncommon complication. It is characterized by ingrowth of the corneal epithelial cells, which are stratified epithelium at the interface between the flap and the stroma in LASIK and between the cap and the stroma in smile. This is a beautiful classification given by Probst and Machat many decades ago, which actually discussed about how the epithelial ingrowth should be tackled as you are actually going, let's say, progressively more in gradient. Vast majority of this epithelial ingrowth, fortunately, are innocuous and they're non-progressives. They need only observation. Many of them would actually disappear with resolution. But we are more worried about those progressive grade 2 or grade 3 epithelial ingrowths which have thicker cells, discrete cells with epithelial nests, and there is no demarcation line. You can also see that there is a kind of slight rolled up edge at the edge of the flap and many of them are known to have epithelial fistula. These are the ones which require intervention, mainly in the form of debridement, which has to occur on the surface of the stroma and also under the surface of the flap as well. You have to be sure that you are not damaging the surrounding epithelium, and of course you can use any adjuvant agent such as absolute alcohol or mitomycin C if it is required. And of course, at the end of the story, you have to put the flap back in its position and basically put a BCL if you want. Many of these epithelial ingrowths also are known to recur, and if there is a recurrence after the first intervention, there can be additional tools to your armamentarium, such as using antimetabolites such as mitomycin C. You can also secure the flap to the stromal bed using a 10-0 nylon or a fibrin balloon, especially if you have epithelial fistula that you can locate. If it is a very discrete and peripheral epithelial ingrowth, you can use Nd:YAG laser at a very low energy setting, and many of these entities have to be doubled up with a very fine 10 micron PTK to smoothen the surface. Fortunately for us, the aggressive ingrowths which go into the stage 4 are extremely rare. This is one of these cases which had presented to us about a decade back. This was a patient who had undergone LASIK enhancement 2 times in the peripheral centers elsewhere, and the patient had, after the first enhancement, second enhancement actually had epithelial ingrowth. This was a hyperopic patient who underwent, and that time you can see that there was a very high irregular astigmatism which had actually gotten induced because of the same. This patient, of course, we could not, there was no way that we could do a flap lift and epithelial ingrowth removal because there was a flap melt in place, and we had to debride this epithelial flap. And as you can see, this was a paper that we published about a decade back, in which a flap amputation along with for PTK and the mitomycin C demonstrated a great outcome in this extremely severe case. This is another case that was referred to us about 4 years back, and you can see there is a huge amount of epithelial ingrowth. The patient had already received 3 times epithelial ingrowth treatment in the form of flap lift and scraping using mitomycin C, so on and so forth. There was already a lot of thinning over the epithelial ingrowth on the flap, and there was a flap melt in place. So again, in this case, we had to go back and, of course, excise this flap, do a flap amputation, do a bit of mitomycin C, and a very narrow amount of PTK of 10 micron. And you can see from the preoperative 3 meters, the patient actually improved to 6/9 outcomes by this approach. So this is the way the epithelial ingrowth is generally tackled. Fortunately, most of them are extremely innocuous and we don't have to deal with them. However, compared to LASIK, the epithelial ingrowth in SMILE is even rarer because we have a very small cut. In fact, these are 2 large series of SMILE. As you can see, one by Sugandha et al., the other one is by Versen et al. Both of them in thousands, and in none of them they actually had any case of progressive epithelial ingrowth. In fact, there are only 2 cases which have been reported of progressive epithelial growth post-SMILE, one of them from India, from NN, the other one from France. But in both of them, they actually tried to go from the small incision to debride the epithelial growth, and there was a recurrence 2 or 3 times and had to be used in the form of glue. So this was an interesting case. This was a patient who was referred to us. She had undergone SMILE about 3 months ago. In one eye, she was doing extremely well, but when she presented to us, she had a poor visual acuity of 6/36. With a very high amount of mixed astigmatism. When we saw the patient on slit clamp, we could see there was a very discrete isolated epithelial cell nest in the visual axis. You can see it in the OCT as well, and this has resulted in a high amount of mixed astigmatism in this patient having a very poor visual quality and quantity. When we did the fluorescein stain, we could see that the incision of the small incision that we take in SMILE was actually quite intact, and it was devoid of any epithelial fistula. So this was extremely important for us to know how to approach this case. So as we discussed, there were 2 cases which are already published. In both of them, they had gone through small incision, and in both of them, there were a high amount of recurrences. There is one patient which is published already with YAG laser, but that was in the periphery. So as Thomas Edison says, there is a better way to do it, and we have to find it. So in this case, we actually used in a novel way the circle software, which is used typically as enhancement modality for SMILE, which allows the conversion of SMILE cap into a flap by those extra additional femtosecond laser pulses which come in a donut fashion. This is how the circle software works, and as you can see, there is something called a junctional cut which goes 10 or 20 micron above and below this junction of the side cut of the new circle donut versus the initial lamellar cut, and you can open up the same lamellar flap. So as you can see, this is the Circle software that I'm using. This is how we have got an entry into the interface of this post-smile epithelial growth. One of the most important things that you want in epithelial growth is to have the full access so that you can debride the epithelial growth completely. And the way that you can have access is by basically creating a flap with the help of Circle, in which you can now open up the entire lamella cut, and now you have full access to the epithelial growth. You can use any kind of spatula to debride the epithelial growth, epithelial cell nest from over the surface of the stroma and under the surface of the flap as well. Once this is done, then of course you can use any tool of your choice like mitomycin C, put the flap back in its place, and after this novel use of Circle, we could see that the patient did very well. This just 1 week after the procedure, the patient improved from 636 to 609 with a very small astigmatism. We published this case in GRS 2 years back. So basically the take-home message is that progressive epithelial growth, fortunately it is uncommon both post-LASIK and post-smile. Post-smile it is even rarer. But it is important to note the mechanism of epithelial growth. If it is post-smile, is it because of the intraoperative potential implantation versus post-operative due to the epithelial fistula? And depending on that, your modality of management will change. And of course, the use of Circle software can be used as a novel alternative to management of epithelial growth in very well selected patients. Thank you very much for your kind attention. Thank you. Thank you.
Moving on to the next session. Thank you, Jyot,
you.
and thank you, Dr. Gupta, for being here.